All right, so we're back for lecture number 2 of neonatal pulmonary disorders. To begin off this lecture, we're going to talk about persistent pulmonary hypertension of the newborn. So this is, we've talked about this before. This is kind of a complex disorder. There's a lot of kind of risk factors or contributing factors that can cause PPHN, but typically, at its roots, you should be thinking about PPHN or causes of PPHN as anything that causes patients to return to fetal circulation. So after the baby's born, if the pulmonary vascular resistance does not decrease, then patients are going to revert back to fetal circulation and have that right to left shunt. And very severe hypoxemia because you are not going to be getting blood to the lungs in order for it to get oxygenated. So that is going to cause severe hypoxemia. These patients also end up with metabolic and respiratory acidosis typically. So kind of that pathophysiology is that right to left shunt is going to be in place through that foramen ovale, the patent foramen ovale, and then through the patent ductus arteriosus. Okay, so they kind of break it down. Your book kind of breaks it down into 3 main types of PPHN. So for causes, so that's your vascular spasm, anything that's going to trigger the pulmonary vasculature to constrict. Typically, this is hypoxemia, is going to be a big cause of it, or pain. Increased muscular wall thickness, this can be kind of a chronic condition, or any decrease in the vasculature that was developed in the lungs is going to cause that PPHN. So these are kind of your 3 fundamental types, if you will, of PPHN. Okay. So how does this present itself? Typically, PPHN is going to present by, you'll see those changes in the SpO2 because of hypoxemia. You're going to have a decrease in the pulse oximetry. Usually we're going to kind of get a definitive diagnosis, they're going to request pre and post ductal SpO2s. So if you have this as your clinical simulation patient, you're going to want to order pre-postal SpO2s. This is kind of never a wrong thing to get on a patient because it doesn't cost much. It doesn't waste much time. All you're doing is putting a pulse ox on their right wrist and then a pulse ox probe anywhere else on their body, and you're looking for a difference. So if the preductal, the right wrist pulse ox, is 10% or more higher than the postductal pulse oximeter, that indicates PPHN. So that kind of that 10% was always kind of the basis. So your book mentions greater than 5%, but most other references that I've seen, and when I worked in the NICU, we used 10%. Okay. Because that difference between 10% indicates that right to left shunting. Okay. Okay. Okay, so how do we treat it? We're going to look to treat any underlying causes. So if it's hypoxemia, we're going to make sure we're giving the patient oxygen or surfactant for RDS. Typically, we're going to try to intubate these patients, put them on mechanical ventilation, and sedate them. Inhaled nitric oxide is kind of one of those gold standards for treatment of PPHN. It is FDA approved for the treatment of PPHN, and it's been demonstrated to reduce both the need for ECMO with these patients and mortality rates. Okay. So typically you're going to do early nitric oxide with these patients. Sometimes they'll want you to get an OI on the patient. So oxygen indices are one of those calculations that we do to kind of just assess how well the patient's oxygenating. So the oxygen indice calculation is actually, let me get my pointer thing. It's going to be your FiO2 times your mean airway pressure divided by your PaO2. Okay, so this is how you're going to calculate out your oxygen indices. The lower the number, the better the patient's doing. So typically you're wanting an OI of less than 25. That is typically the means that your patient's oxygenating well. Once it gets above 25, that's when you should start considering using nitric oxide. And then if it gets above 40, that is when you should start considering using ECMO and other types of like extreme measures to correct this. All right. So congenital abnormalities affecting respiration. There's several here. So different airway diseases, lung malformations, diaphragmatic hernias, abdominal wall abnormalities, and then neuromuscular control issues all fall into the kind of this category. So airway diseases, there's three kind of, again, fundamental mechanisms of airway diseases. You have your internal obstruction. So this could be obstructions inside the airways, like your tracheal or laryngomalacia. Babies can have laryngeal webs or tracheal stenosis. Hemangiomas are like blood blister type things inside the airway. Stridor, gas trapping, wheezing, accessory muscle use are all going to be kind of the clinical manifestations of those internal obstructions. External obstructions the symptoms are going to be very similar. These are obstructions that are happening outside of the airway, but are kind of compressing on the airway. So those would be some examples of that would be neck or thoracic masses or vesicular rings, can all be obstructions outside of the airway that can compress on the airway and cause issues. Okay. Oops. TE fistulas. This is one that your book kind of calls out because it's a common airway disruption in babies. This is usually, there's 5 different types. So this is where you have like an esophageal atresia that's going to cause like a fistula in the airway. You can have esophageal atresias, like narrowing of the esophagus without a fistula. So I think actually there's a better kind of picture. Ooh, actually, never mind, this edition doesn't have the good picture of this in your book. I'll see if I can try to find my TE fistula picture and publish that separately. This regardless of what type it is, how it's formed, most of these babies are going to present with difficulty swallowing or a lot of drooling secretions in their mouth because there's nowhere for those secretions to drain. They could also have a lot of choking and aspirations because, again, the whether it's the esophagus isn't completely formed, it doesn't empty into the stomach, or the esophagus, is attached to the trachea and the baby's aspirating right down directly into the lungs. That can cause this frothing at the mouth, a lot of choking types of symptoms. These babies are going to need to go to Children's Hospital to get surgery to correct. All right, I actually just Googled this really quick because I do want to just give you that visual when we're talking about TE fistulas. So this is your esophagus here. This is the trachea and this is the stomach. So in this type 1, you have the esophagus ending abruptly and not going anywhere. So if a baby would eat or try to swallow, this little segment of the esophagus would store those secretions, but then when it got full, then those excess of secretions are going to enter up into the upper airway and then possibly get aspirated down into the trachea. Okay, so to treat, if you have a patient that has a kind of disconnected esophagus, or this esophagus ends in like this little pouch here and doesn't connect to anything, which is in example 1 and example 3 here, which is the most common type. What ends up happening with these babies is a lot of times, actually any of these patients, really you're going to want to put an NG in and put it to suction so that this NG, and on chest x-ray, you'll notice that the NG is like coiled up here. And that's usually a way that we can confirm that the baby has a TE fistula. You can put that onto suction to suction out those secretions and help manage those secretions until the baby can go to surgery. This type of TE fistula, you have the esophagus that does not connect directly to the stomach, but does have a connection to the trachea. So as this esophagus fills up with secretions, it's going to empty directly into the trachea, and the patient's going to be aspirating a lot. So you're going to see the baby kind of be blue, coughing a lot, choking, having those choking signs. This is the most common type, where the esophageal kind of bubble here doesn't connect at all to the trachea or the stomach, but the trachea is connected directly to the stomach. So in this type of TE fistula, the other complication is that the air is going to then enter into the stomach from the trachea. Once it gets into the stomach, it has a hard time getting out. There's no way for me to decompress the stomach. So this stomach is going to become distended with air, and that can compromise ventilation. Same thing with this one. You have the aspiration risk and the inflation of the stomach risk, as well as this one, where the stomach can become distended with excess amounts of air. So it's good to kind of look at these to kind of understand how these babies are going to be presenting. So typically, if you have a TE fistula or suspect a TE fistula, you're going to want to drop an OG or an NG into the baby. Get a chest x-ray. You should see that coiled up. In most types, you'll see that NG coiled up. This is the only type where you wouldn't see it coiled. You'll see it coiled up in that esophageal pouch at the top of the x-ray, which kind of helps confirm your diagnosis, and then the baby will go to Children's to get it corrected. All right, back to the PowerPoint. Okay, so now we're going to talk about some lung malformations. So the most common lung malformation is going to be congenital pulmonary adenomatoid malformation. That's a hard one to say. So this has kind of this is kind of a cystic disorder. It's classified into kind of 5 different types based on the size of the cysts. This disorder is going to can affect different amounts of lung space. So it can take over an entire lobe of the lung, and obviously depending on how much of the lung turns into kind of the cystic area, that's going to create some volume loss. So the more the lung is more of the lung that's affected, the more volume that's going to be lost for the patient. So these affected parts of the lungs are not going to participate in gas exchange. And Usually treatment is going to be kind of doing a surgical resection and taking that out. Okay. If this patient is, in severe cases, this can be the patient can have cardiopulmonary compromise. Another thing that's kind of related to this lung malformations is a disorder called hydrops. I think Joe talked about this with you guys in class a little bit. Hydrops fetalis is a very serious fetal condition. It, usually is like demonstrated by like a accumulation of fluid in in the in the body. So these babies look really edematous. Um, and this can cause like the systemic edema compartment syndrome with the babies. These babies tend to be very, very, very sick. Some other less common lung malformations are going to be things like pulmonary sequestration or lobar emphysema. Both of these are, typically due to like underdeveloped lungs. Um, uh, and can cause like gas trapping and restriction in the babies for the babies. Okay, so another disorder that we've talked about a bunch in the past is our congenital diaphragmatic hernias. There are two types that your book breaks down. Not as much important that you remember this, but you have your Bachdelic hernia or your Morganine hernia. I'm probably not saying either of those right. But remember, what's happening with congenital diaphragmatic hernias is the intestines and the abdominal contents have herniated into the thoracic area that is compressing on the lung tissue as it's trying to grow and develop. And we should know by now from our conversations from earlier on this semester that compression of that lung tissue is going to lead to that lung hypoplasia. Okay. And those lungs are going to be immature and have abnormal development. Okay, so typically these babies are going to present with a scaphoid abdomen, very, very diminished breath sounds, it typically happens on the left side, so diminished breath sounds on the left side. Because that abdominal content's all in the left side of the chest, it's pushing everything else over to the right. So you're going to see those displaced heart zones. They're going to be more to the right. The baby's going to be very cyanotic. Again, this is extremely restrictive. You're not going to be able to ventilate these babies well. The baby's going to look like they're in a lot of distress. And we usually confirm diagnosis with chest x-ray. So for treatment of this, we want to make sure we're intubating quickly. We're not going to be providing PPV to these patients with a bag and a mask because we're really concerned about any excess air entering into the abdomen, which our abdominal contents are now in our thoracic cavity. So any free air that's getting into our stomach is going to make ventilation that much worse. So we want to intubate right away, paralyze the patient. And then we want to potentially these babies until they can get the surgical repair. We want to make sure that we're supporting them with like lung protective strategies. These babies might get put on ECMO. These babies might be indicated for high frequency ventilation. So typically also these babies are going to be put on like an NG, OG tube, and it's going to put on continuous suction. That's going to help with that ventilation and oxygenation. They're not typically, most places your book mentions don't do surgical repair right away. They usually wait a little while to close the defect and, fix it. But babies can end up with pulmonary hypertension also with, they have diaphragmatic hernias or at risk for pulmonary hypertension due to that pulmonary vascular restriction. So, those are typically the ones that end up on high frequency or ECMO. Um, Abdominal wall abnormalities. Most babies are primary abdominal breathers, so any abdominal wall abnormality is going to affect the respiratory system as well. Um, so any large defects to the abdominal wall can cause severe respiratory distress and need mechanical ventilation. So the most common one of these are your omphalocele. This is where we've talked about this before, that umbilical wall is open and the uh, like umbilical cord or the baby's bowel goes into this omphalocele, which is this, kind of bubble of, lack of better term, guts that are outside the body that should be inside the body. So these, I never share pictures of this because it's gross, but you can look it up on your own if you'd like to. These then, if you have this omphalocele, the baby is going to go to surgery to get it repaired. Usually, initially, they're going to just put wet dressings on top of it to try to keep it from drying out. But that is a surgical repair. Neuromuscular controls. So there's a lot of different disorders out there that result in poor neuromuscular control of the diaphragm. So that could be your spinal muscular atrophy. Congenital myasthenia gravis is a possibility, just like myasthenia gravis in adults. Myotonic dystrophy is a neuromuscular disorder that's congenital, so babies have it from birth. These diseases, again, if you think about it, my respiratory muscles aren't strong enough to do my breathing adequately for me, so it's going to cause restrictive lung disorders where I'm not getting good volumes in. So these babies might need respiratory support. Okay. So either non-invasive or invasive respiratory support to help them with their breathing. All right. All right. So congenital heart diseases, this is, there's a whole chapter in your pediatric textbook about congenital heart diseases. Again, I didn't assign it, but I recommended it earlier on in the semester to those of you that are very interested in going into neonatal pediatric care, because they're, there's quite a few of them. You're not going to be asked extensive knowledge on congenital heart diseases for your MBRC, TMC exam, but it's good to have kind of a, general knowledge of these disorders. So there are they get broken into two categories: cyanotic or acyanotic heart disorders. So if you think about it for a second, cyanotic heart disorders are where blood is going to be shunted from the right side to the left side of the heart, bypassing the lungs. So if I draw this out, your cyanotic heart disorders, this is the right side of my heart, this is the left side of my heart, and this is my lungs here in the middle. So in cyanotic heart disorders, the blood just goes like this, right? So this would be like a PPHN is a congenital disorder where blood is shunted from the right side of the heart, not congenital, but right side of the heart to the left side of the heart. So cyanotic heart diseases are the same. They bypass the lungs completely. The blood never gets oxygenated, and your babies are going to be blue and have a lot of hypoxemia. In acyanotic heart diseases, the process happens differently. So I'm going to change my color, where the blood goes the correct process, but then instead of getting pumped out of the left side of the heart, it goes back to it shunts backwards to the right side of the heart. So this is, oxygenating blood is being circulated, but it's not going out to the body the way it's supposed to. It's not going here. So that is causing that congestive heart failure where blood is kind of cycling back on itself and causing issues. Okay. Okay. So your cyanotic congenital heart defects, a main one that you might hear about is called tetralogy of Fallot. I think I'm saying that right. This is kind of signified by pulmonary stenosis, ventricle septal defects, dextroposition of the aorta, meaning the aorta is kind of flipped around, um, and then right ventricular hypertrophy. Um, so this is, there's different severities of this disease. It can be fairly mild, where it's, still diagnosed in early childhood, or with severe diseases, this is gonna be diagnosed pretty much right in that newborn phase before the baby leaves the hospital. Okay, so in mild form, you might just hear like a murmur with the baby. Um, uh, they might have some intermittent cyanotic spells throughout their early childhood with severe forms of the disease. These babies are going to present with a loud murmur, severe cyanosis, and then pretty much the main characteristic that you're going to see with these patients that's significant. Anytime you see boot-shaped heart on the chest X-ray, that indicates that this is probably a tetralogy of Fallot patient. I just actually did my CMPs, my continued maintenance education credits for my NPS, and this was one of my exact questions on my little mini quizzes. Was they gave me the boot shaped heart, and I went, oh, I know what that is. That's tetralogy of Fallot. So don't think you're going to be getting these on the TMC, but if you guys go do neopeds like I did, you'll be expected to know stuff about heart disorders, especially if you work at Children's. Transposition of the great arteries. This usually looks like moderate or severe cyanosis at birth. Usually these babies are going to have that oxygenated blood is going to be dependent on that patent ductus arteriosus. So we want to make sure that they do emergent surgery so that they've tracked the blood flow before that PDA closes. Okay. So after they do that, it's called a atrial septostostomy, which, you're really just cutting a hole in between the two atria. That's going to relieve the distress. And then that buys them some time. And then a couple weeks later at life, they'll do more extensive surgery. This is classified usually with an egg-shaped heart on chest X-ray. Okay, your acyanotic congenital heart defects. This is your VSD and your ASD. These are holes in that septum between the right side and the left side of the heart, between the atrial or ventricles, depending on which one you're talking about. So this is going to cause blood to kind of flow back into the right side of the heart rather than getting ejected from the left side of the heart. So we've talked about patent ductus arteriosus before. This is typically occurs in those premature babies. It's always going to be open, but every baby has it open when they're born, but most of the time it's going to typically close within a couple days of birth. It's going to act like that right to left shunt or a left to right shunt, depending on which pressure is higher. So if my systemic vascular pressure resistance is higher, the blood is going to want to flow back through this to the right side of the heart. If your pulmonary vascular resistance is higher, it's going to flow from the right to the left side of the heart. So depending on where the vascular resistance is greatest, the blood is going to scoot through the other way. So treatment of this, usually pharmacological. They'll do like indomycin, is one medication that we give to close these. Ibuprofen is another one. Um, and then if that doesn't fix it, they will sometimes do a surgical ligation where they go in and put a clamp on this ductus arteriosus to close it off. Ligations have become less popular in recent years. Okay. All right. You've got your uh excuse me, your left ventricular outflow obstructions. So these are things that are going to interrupt the blood flow through that aortic arc. So typically one of the main ones of this is going to either be aortic stenosis, coarctation of the aorta is another one, or hypoplastic left heart syndrome. All of those are disorders that are going to affect the blood flow out of the heart. Okay. So there are some really good pictures on page 712 and 713 in your book that kind of help you visualize some of these disorders. So typically what we will do for these, sometimes they might treat them with prostaglandin E1. That's a typical treatment for these types of obstructions. So you remember those prostaglandin medications are vasodilators. So those are helpful to, you know, uh, increase the diameter of your vasculature and reduce that afterload. In severe cases for this, you might need to put the patient on mechanical ventilation and they might need a surgical intervention. Okay, so that is an example of one of the pictures from your book. This is that left hypoplastic heart, which just shows that very small left ventricle. Again, on page 712 of your book, there's a lot of different other pictures that kind of help demonstrate some of these defects. Right. All right, so with your pediatric respiratory disorders, so typically your pediatric issues are going to usually stem from some type of airway obstruction or infection. So this might include like things like asthma, GERD, cystic fibrosis, epiglottitis, croup are viral based or bacterial based infections. So those are usually what's going to happen with our pediatric kids. Sorry, Fritz was barking in the background again. All right. So sorry, clicked over. So with these types of disorders, you might see patients with sorry. Now I'm on the right page. Sudden infant death syndrome. So sudden SIDS is, going to be kind of your leading cause of death in patients less than a year old. Typically by the age 18 months, this becomes less of a concern. So, obviously the causes of SID are not really well understood, but there's a couple of recommendations that American Pediatric Society makes for prevention. So that's just identifying those at-risk patients, giving education to family on just monitoring their babies, especially if they're premature, for apnea, how to perform like CPR until additional help can get there. The back to sleep movement of placing that patient supine or side lying instead of on their stomach, not having a lot of toys or blankets or soft objects in the crib that they might like roll over and suffocate against. Some other risk factors, I think, co-sleeping is a big one. They really recommend not co-sleeping. Um, houses where mom and dad smoke, there's usually a higher instance of SID as well, so not smoking around the baby. Those are all kind of things that we can do to try to help prevent it. Um, so typically most SID cases happens in babies less than 6 months. Winter seasons usually when it happens the most. Maybe it's because we think we need to put extra blankets on our babies. Happens when the babies are asleep at night. It's very common in kids that have had maybe mild illnesses before it ends in infant death. Again, we don't want to have our babies sleeping on their stomach, and moms who smoke have a bigger risk for SIDS. All right. GERD. GERD is a regurgitation of that stomach contents into the esophagus. So it is kind of common in childhood. I think sometimes they call them happy spitters. I had a happy spitter baby who just threw up every single thing that we ever fed her. For no reason whatsoever until she was about 6 months old. So the risk with this is that you can develop some different respiratory disorders. Reactive airway diseases, asthma, and GERD are closely linked. I don't know if it's just because of those potential of that that aspiration of that stomach content can cause reactivity in the airways, can cause pneumonia, laryngospasm, chronic cough. Stridor, when babies do this, they tend to just decide that they're not going to breathe anymore, so they become apneic and their vocal cords close. So a couple different reasons, a couple different things that can happen with GERD. A lot of times people assume GERD is just for grown-ups, but a surprising number of children will have it as well. So typically it's diagnosed with esophageal pH testing. They'll do like upper GI contrast studies, and scanning. And then typically after it's diagnosed, they might put the patient on some medications to help reduce acid content, or they might even have to do some surgery to manage it. Okay, so bronchiolitis. This is usually caused by RSV. So it's usually a upper respiratory infection, RSV, causing that acute infection of the lower respiratory tract, which is going to cause some bronchiolitis. So, so typically these babies are going to present with a lot of upper airway secretions. They might have a fever or cough, increased work of breathing. Then you might notice those inspiratory, expiratory wheezes. And then on chest x-ray, because it is swelling of those bronchioles, those air passages, you might see some gas trapping and hyperinflation on the chest x-ray, or you can see some consolidation from, secretions and such. So typically to diagnose bronchiolitis or RSV, they're going to do a kind of a lab test. So they will do like an assay test to identify the RSV. And then they will start the treatment plan. So treatment is usually focused around relief of the airway obstruction and hypoxemia. Okay, so the most recent guidelines from the APA are going to recommend that these patients are parents try to manage these patients at home with just proper suctioning and humidification, any types of oral decongestants to try to help with all the upper airway secretions. And we reserve hospitalization and oxygen for those patients who are maybe not eating anymore because of all their upper airway secretions, or if they're hypoxemic or dehydrated. Okay. So typically then we would maybe admit them to the hospital, put them on some oxygen if needed, if indicated. It's not always necessary to treat these babies with high flow oxygen. Airway clearance with just suctioning is, primarily the way we're going to treat this. Um, if the baby is an acute failure, then you can consider mechanical ventilation. Okay, but sometimes with uh, bronchiolitis, less is more. We used to do a bunch of crazy stuff with bronchiolitis where we would, put them on nebulizer treatments and do CPT and do all these other things, and we really found that that doesn't really help anything out. So just making sure that if these parents come into the emergency room with these babies, making sure that they don't understand how to suction properly, and can identify when the baby needs to be suctioned. So that patient education is important. And then you're only going to really admit them if they appear dehydrated or if they need supplemental oxygen after proper suctioning. Okay, croup. So croup is another one of those viral disorders of the upper airway. It's going to cause that subglottic swelling and obstruction. Okay, so sometimes they refer to it as laryngeotracheal bronchitis. Okay, it's usually caused by that parainfluenza virus, which it's less common now because we vaccinate, right? Give kids flu vaccines. It can be caused by strep or staph as well. So usually it's seen in babies 6 months to 6 years old. It kind of presents itself following 2 to 3 days of nasal congestion or fever or cough. And you're going to see that inspiratory stridor and that barking cough. Okay. Um, as it worsens, you're going to see dyspnea, cyanosis, or even exhaustion. The croup kids, those 2-year-olds who are just very, very, very sleepy looking, are the scary ones because that usually means that they are tired out from this. A kid that is in respiratory distress and the beginnings of respiratory stress is going to be very agitated or irritable. But as they get tired out, they're going to get real, real, real complacent. And that's always a scary sign. That usually indicates that this kid's going to tip over the other end and we're going to be intubating soon. So the chest x-ray you're going to want to, or radiology you're going to run and recommend is, you want an AP chest x-ray, and you'll see that steeple sign on it. But usually they want a lateral decubitus as well, just to rule out epiglottitis. So that's where that steeple sign is. If you look very closely, let me see here. Draw on top of this here. Okay, so this is the trachea down here. I'm gonna outline it. This is my carina. This is the trachea going up here. And then you see how it really narrows right in that area. And that is the steeple sign. So it's supposed to kind of look like a steeple. If you think about a church steeples look like that. Top of the church. This is the church. It's my very bad church drawing. Okay, so the steeple there looks like the steeple of the trachea here as it narrows in that area. So I'm going to get rid of my drawings so hopefully you guys can see that. Okay, so treatment. What are we going to do for our croup kids? Mild to moderate, you're just going to do cool mist aerosol without supplemental oxygen or with it, depending on their SpO2. So cool mist aerosol would mean that you would be starting them on an air entrainment mask. Corticosteroids can be effective, and epinephrine. So your corticosteroids and aerosolized racemic epinephrine are going to be indicated here. So typically those are ordered right away. Sometimes we may add budesonide because again, that's an inhaled corticosteroid, so that might help. But usually we're starting with Decadron to help with the airway edema. If your patient is bad enough, they're going to need to be intubated and put on a mechanical ventilator. You could consider Heliox as well with severe disease. Heliox again has that low density. It's able to fit through narrowed passages easier than just straight oxygen, so you might want to consider giving the patient Heliox. Epiglottitis, this is a life-threatening infection of that upper airway that's going to cause supraglottic swelling, meaning swelling above the vocal cords. Again, there's a lot of evidence that shows that epiglottitis is decreasing among kids, but we have more instances of it in adults, and that's usually related to, again, vaccinations. Influenza is usually a cause of epiglottitis. Clinical manifestations, typically these kids have higher fevers than croup kids. Croup kids don't have as much of a fever as epiglottitis kids. They're going to have sore throats, swelling, labored breathing. They're also going to have that presence a lot of times of drooling, difficulty, like their voice will sound kind of muffled, and they're not as common to have that croupy, barky cough. That it's not as common to see that in epiglottitis kids as in croup kids. Okay, so you are going to want to get a lateral x-ray of the neck, and that is going to show the hitchhiker thumb sign, okay, from the swollen epiglottitis or epiglottis. If you look in your book on 716, you will see that prominent thumb sign that indicates that the epiglottis is very swollen and is obstructing that airway. So the proper treatment for this is sending these kids to OR to get electively intubated. Okay, I think we had this question. And I think maybe a lot of you came up and asked me about this even, is that if you have a kid that you suspect have epiglottitis, you are not intubating in the emergency room. This kid is going to go to OR so they can be intubated in a controlled environment, and that if they for an unsuccessful intubation, we can put a tracheostomy tube in emergently. Corticosteroids also might be indicated to help with decreasing of the swelling. Okay, and again, because of the edema in the airway, we want to make sure that these kids don't self-extubate themselves. So these kids typically get heavily sedated after intubation before getting sent to the PICU. So this is that picture in your book that kind of just shows that thumb sign in the airway that indicates the swollen epiglottis. All right, cystic fibrosis. So your cystic fibrosis kids, this is a autosomal recessive disease. So that means that you have to inherit this genetic mutation from both of your parents in order to have it yourself. Okay. This genetic mutation is a mutation of a part of your genes that produce a protein called your CFTR protein. This is going to affect that chloride movement in and out of the cells. Okay. So these babies are going to have issues with like their sweat glands, their pancreas, and their lungs. Typically, one of the clinical manifestations of this is moms will say that their kids taste very salty when they're kissing them. We use a sweat chloride test to diagnose these babies. Two sweat chloride tests above 60 indicate the presence of the disease. Some other indications might be that because of that pancreatic involvement, these babies usually present as failure to thrive, meaning that they look kind of malnourished or they have struggled to gain weight. They also have like greasy stools because they have a hard time digesting the fats in their diet. Lung disease is going to be the leading cause of death in these types of patients because they get the pulmonary infections because of copious amounts of secretions. Okay, so big things with CF is monitoring. So we want to make sure that we are screening our babies for CF. Typically, all babies after they're born will have a blood panel sent to the state blood screening panel, which will identify at-risk populations for CF. So every single baby, whether you have a history of CF or not, will get this screened in the state of Wisconsin on their blood screening panel that the hospital does. If anything comes back suspicious on that, then they would be recommending those sweat chloride tests. Um, if um, if they show positive on the sweat chloride test, they're going to probably get genetic testing as well. Okay. So as like CF as CF patients age, they're going to be monitored closely for their symptoms. They're going to do physical exams, a lot of sputum cultures on these patients to look at the like microbes or flora in the lungs. A lot of times they'll do spirometry and routine spirometry and chest X-rays, and also these patients, again, because they have difficulty with digestion, they're gonna have their growth body indexes monitored fairly closely. Okay, so for treatment of these patients, typically they are going to be, we're going to do multiple things to try to maintain their lung health. Airway clearance is going to be a key objective. That might be percussion, postural drainage, PEP therapy, autogenic drainage, um, oscillatory PEP therapy, vest therapy. Um, so this these are going to be the kind of the mainstays of their treatments. So there's not necessarily one that's going to be better than the other. You just want to make sure that you're tailoring which device you're picking for the patient to the patient's needs. Another medication that we typically order for CF patients and really are kind of only used in CF patients is DNase. So that's pulmozyme. This is a medication that helps reduce the viscosity of secretion, so it thins secretions out. It's like an enzymatic, so it kind of breaks down the enzymes in our mucus and helps with clearance. Hypertonic saline also is helpful with that because it, hydrates our secretions, helps remove them. If there's presence of pulmonary infections, these patients are usually on antibiotics like azithromycin or nebulized tobramycin. So those antibiotics are usually recommended for patients. Aztreonam is another inhaled antibiotic that could be used. And this is because these patients tend to have a lot of infections with Pseudomonas. Then interestingly, they have new CFTR regulator medications that are out there. So these are medications that actually help directly with the mutation. There's, I think ivacaftor, I think is one of them. Um, that medication works to kind of decrease those concentrations of chloride. And then there's a couple other different ones that are out there. They're also doing a lot of genetic uh, therapy, or working on genetic therapy to like correct the mutation. So one of the newest things out there, it's really interesting. I should find the TED talk on it. It's called the CRISPR, and this is a gene therapy where they introduce a virus with a corrected gene sequence into patients, like CF patients, and actually kind of use that virus to reset the gene sequence. It's very interesting. I should find the video for you guys and publish it, but it's a very interesting new therapy that's out with this. These patients also can be on anti-inflammatory agent and bronchodilators as well, like albuterol and inhaled corticosteroids. I think that is it. So, all right. Well, I look forward to listening to each and every one of your disease presentations. And if you guys have any questions, please let me know.